Hello, everyone. Thank you so much for the opportunity to be here today. My name is Dan Spielman, and today I'll be presenting our research titled Variability in Sinonasal Allergen Deposition Explains Asymmetric Involvement in CCAD. Before I get started, I just want to thank all of my co-authors, without whom this work certainly would not have been possible. Listed here are disclosures from several of the members of our team, but these are not related to the topic at hand today. I'd like to start off by providing a brief background about central compartment atopic disease, or CCAD as I'll refer to it. This disease process was first characterized just 5 years ago in 2017. At that point, it was recognized that there's a subset of patients who have chronic rhinosinusitis with nasal polyps who have somewhat of a unique phenotype. These patients have nearly 100% sensitivity or response to inhalant allergy. And they have a very unique distribution of disease and inflammation that's different from other subtypes of CRS. These patients tend to have sort of hallmark radiologic findings and distribution of their inflammation and polyps. As you can see here, they have involvement of the septum, the middle turbinate, and the superior turbinate, resulting in this sort of central opacification and distribution of the inflammation. The surrounding sinuses are relatively spared as compared to other types of CRS, so they tend to have lower Lund-Mackay scores. And in a little bit more advanced disease, the middle turbinates become lateralized and obliquely oriented. Importantly, these patients tend to do quite well. When they need surgery, they tend to have low rates of polyp recurrence and low rates of requiring revision endoscopic sinus surgery. Illustrated here is a coronal CT scan of the sinuses in a patient with typical central compartment atopic disease. What I want to highlight here is the distribution of inflammation and polyps that is most significant centrally within the nasal cavity, involving the septum and the middle and superior turbinates. And we can see that while there are some post-obstructive secretions, there's a relative sparing of the sinuses peripherally. If we go ahead and look at the corresponding nasal endoscopy, here we're looking on the patient's left side and left nasal cavity. And we see here that there's polypoid degeneration of the head of the middle turbinate. There's also polyps coming off of the septum itself. And these findings are specific and unique to CCAD. These septal polyps are actually displacing the middle turbinate laterally and causing it to be oblique in nature. If we go ahead and look at the EPOS 2020 guidelines, there's a focus on delineating types of sinonasal inflammation based on their anatomic distributions. Now, central compartment atopic disease, illustrated here, is a type 2 endotype that affects both sides of the nasal cavity and is therefore classified as diffuse in nature rather than being localized. And now if we think about these diffuse processes, and especially the ones that are mediated by a systemic immune or allergen response, one might expect that their bilateral sinonasal cavities would be affected in a symmetric manner. But we know that that is not necessarily always the case. So here we're looking at scans from two different patients who both have central compartment atopic disease. And both of them have inflammation present in bilateral nasal cavities. But what I want to highlight is that there's asymmetry from the right to the left side in both cases. They both happen to have disease that's worse on the right-hand side. And we noted that we were seeing this with some regularity, that while patients typically have inflammation on both sides, it's not uncommon for one side to be worse than the other. And so we asked ourselves, why is this happening? Why is it that in this diffuse disease process that we understand to be allergen mediated, why would one side oftentimes be worse than the other? We know that differences in airflow can exist between an individual's right and left nasal cavity. And we hypothesize that perhaps there are differences in deposition of allergens that exist between the right and left side of each person's sinonasal cavity, such that if there are differences in the amount of allergens that are depositing on each side of the nose, then someone who has atopic sensitivity or pathology perhaps would then go ahead and develop asymmetry in the distribution of their inflammation. Meaning that, is it possible that this person who has central compartment atopic disease, whose scan is shown here, perhaps this person, because of airflow dynamics, had more significant allergen deposition on the left side of the nose that ultimately caused the development of worsened disease on that side. And so, to test this hypothesis, what we did is we developed a model by extracting data from a CT scan of a 25-year-old who is healthy without sinonasal disease. And we used this to run computational fluid dynamics modeling. And I want to emphasize here that we're using and building a model from a healthy individual because we know that once sinonasal disease has developed, that there are changes in airflow and changes in allergen deposition. And so what we wanted to understand is, at baseline, in patients who are healthy, are there significant differences in deposition of allergens? We know that there are airflow differences. And so perhaps if there are differences in allergen deposition down the line when there's atopy, perhaps that is resulting in differences in disease distribution. After running the model, simulating the deposition of 30,000 particles, we compared the right versus the left side of the nasal cavity to understand where these particles were depositing. We also were interested in the effect of the middle turbinate on particle deposition and evaluated differences in particle deposition both before and after middle turbinate excision. The reason that we're interested in the effect of the middle turbinate is because these patients, it can be, in patients with CCAD, it can be appealing or tempting to completely resect the middle turbinate because it's often very involved by disease. And so we wanted to understand, if you take out the middle turbinate, how does that change the physiology within the nasal cavity? So what we did is we divided the nasal cavity into 10 subsites on each side, pictured here in different colors. And after the CFD simulation, the particle deposition at each site was recorded and compared. So what do we find? Here are part of the results, and we're comparing the right versus the left nasal cavity and the particle deposition on each side. On the x-axis is the particle diameter increasing from left to right, and on the y-axis is the deposition fraction of particles. And each color corresponds to a different subsite within the nasal cavity. What I want to highlight is the differences between the right and the left side. We see here on the patient's right side, there's significantly more pink, which is corresponding to deposition along the head of the middle turbinate anteriorly. Whereas on the left side, there's significantly less pink and a lot more orange that corresponds to allergen deposition along the nasal septum. We wanted to make sure that these differences between right and left sides of the nasal cavity were not unique to a single particle type or size or shape. And so we went ahead and looked at different potential allergen-like particles. And so, again, we simulated here in the top row is comparing the right and left nasal cavity when simulating an aerodynamic sphere, whereas in the bottom row, comparing each side looking at a pollen ellipse, just different types of particle sizes and shapes. And again, the findings were similar. If we look here at the right nasal cavity, again, we see that there is significantly more pink corresponding to deposition along the middle turbinate, as compared to the left nasal cavity, where there's a more orange distribution that corresponds to deposition along the nasal septum. This is an accretion plot illustrating the variability of allergen deposition onto the nasal septum both before and after the middle turbinate is removed from the model. In columns A and B, the middle turbinate is still present in the model, but in column B, it's just removed from the figure so that we can look specifically at the septum in its entirety. And what I want to highlight is, while there is some variability from side to side, the middle turbinate serves this protective role in preventing deposition along the septum where it sits in this area here on both sides. If we go ahead and remove the middle turbinate from the model and rerun the particle deposition, comparing side to side, we see now that there's significantly more particle deposition in those areas where the middle turbinate was previously sitting on the posterior part of the nasal septum, and there is some variability from side to side just in the way in which the particles deposit. Our data overall demonstrate that the middle turbinate serves its protective role in preventing particle deposition along the nasal septum, as well as into the sinuses. I'd like to conclude with some of the key takeaways from our study. Overall, our data demonstrate that according to CFD modeling, based on a model of a healthy individual without sinus disease, there is significant variability in the allergen deposition when comparing the right versus the left sides of the nasal cavity. This variability exists across particle diameter, shape, and size. The most common location for particle deposition within the nasal cavity was on the anterior surface of the middle turbinate as well as the nasal septum. I think it is important to recognize some limitations of this study, which is that this model was developed based on the scan from one individual and a healthy person. We do hypothesize that these differences in allergen deposition may ultimately account for the asymmetry that we see in atopic-related forms of CRS with polyps, such as CCAD. But additional research is certainly necessary to corroborate those findings. I'd like to conclude by thanking our entire team, without whom this certainly would not have been possible. I'd especially like to recognize my mentors at Emory University, John Delgadio and Sarah Wise, as well as the entire team here in Australia, Kiao Inthavong, Narinder Singh, and Patrick Warfield McAlpine. Thank you so much for your attention. I'm happy to take any questions.